4 of Onco Bridge 2025 clinical updates in common cancer. We truly delight to have you all with us. To officially commence today's proceeding, it's my pleasure to honor and invite Dr. Asim Kumar Samar. He is a senior consultant medical oncology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, to deliver the welcome remarks. Dr. Asim Samar, the stage is yours.
Yeah, thank you and good evening to everyone. Thank you, the team Horizon, for making this platform. And today, this is the fourth and the last day of the Onco Bridge webinar. And it was a really wonderful experience of meeting the experts in last 3 days. And today will be the session regarding the lung cancer and the hematological topics, the researches which has come up in the last 6 months, and they have presented in the ESCO and the AISH meetings. So we will be having a fair idea about what is going on in the world, a world of the research and the clinical trials, and how we can implement the acquired knowledge in our practice. So, as you all know, in the scientific world and in the medical field, everyone wants to be updated their knowledge, and this will the true in the true sense it is a service to the patient, because if we don't have appropriate knowledge, we can't do the good service to the patient. We may spare them to having the good medicine or the research molecules and the good drugs which can improve their PFS, this survival and their quality of life. So some medicines are there to improve their quality of life. Some medicine can increase their longevity, and some medicine is to prevent the side effects and other things. So we need to be updated. This is the proven fact, and nothing can be in the form of good service if we can impart the good knowledge of ours and the good experiences of others in our clinical practice. So for that, I would like to invite our first speaker, and very much respected in the nationwide, and he is the, we can see the youngest face of the oncology in the medical oncology department all over in the Jaipur and the Rajasthan, Dr. Sandeep Jasuja. He is our senior and most respected, you can say, the senior doctor, and he is the pioneer in the transplant sector in the Jaipur and Rajasthan, and he is the medical superintendent in the State Cancer Institute and HOD Department of the Medical Oncology, SMS Medical College and Hospitals, Jaipur. And sir will be speaking on the redefining in care of the exon 20 insertion situation. And this is the, you can see the latest era where you can find the new drug and you can have the how to give it and what are the side effects and survival advantage. So, sir, a warm welcome to you, and over to you, sir, for your talk. Thank you.
So, first of all, I'm very thankful to Dr. Asim for giving a nice introduction and giving me an opportunity to be here with you and to discuss latest advancement in the oncology field. And it's first of all, let me congratulate Dr. Asim for doing this all great of us to know about the what is the latest happening and what is latest going in the world in the oncology field. So can you share my slide, please, organizers? So important point is now today we are discussing what we are discussing is about the lung cancer. Now we know the treatment is personalized treatment, and 10 years before when we treat the patients, then we usually have some kind of chemotherapy for this patient, and there are then demarcation was happen in a term of histology
Slides are visible.
type squamous cell adenocarcinoma, and differentiation was done like if we do if that the adenocarcinoma we prefer to give pemitaxi based chemotherapy, and when it's squamous cell carcinoma we do usually paclitaxel and other at all drugs. But somehow over a period of time now this is the era of precision oncology, and now the lung cancer is again divided into their category of genetic analysis, and at now we treat at the target base, and in target base then comes and the EGFR positivity and other mutations and targetable mutation. And in EGFR, we usually do have, when I was doing my DM, then only EGFR was available for the all EGFR patients. But now it's again subcategorized, and we know the more detailed personalized treatment for these patients. And one of them, the subset of the EGFR is insertion 20 mutation. And for that purpose, we have now that is now 20 targetable mutation kind of TK. The one is the big development in this setup. So in my disclaimer, this all slides providing me to sponsor session. So coming to avimentanib, which is first bispecific antibody, fully humanized bispecific antibody, and which target both EGFR and MET signaling, which is the first of its kinds EGFR anti-EGFR drugs, which also not only target EGFR but also MET signaling. And it is specially, this is one of kind of unique molecule which binds extracellularly, so it doesn't affected by co-mutation in EGFR and TK1 proteins. So it has also one unique activity that it also is effective in the patient who are resistant to standard of care treatment of EGFR mutation, MET mutation, and also address major issue who are patients who are resistant to first, second, third line TKIs. Next slide, please. So the action, Eventually demonstrate the three kind of action. This is the unique three kind of action. One kind of action is the by ADC, like kind of ADC binding. It has FC receptor retain activity, which bind to the natural killer cell and promote the natural killer cell to act on the cancer cell, and leads to cancer cell death. And second is by trogocytosis, which is a novel mechanism where they activate the possible novel mechanism. Still, it's not confirmed in the avimentanib mechanism, but somehow it is hypothesized that it also do trogocytosis, where macrophage was activated and they internalize the receptor and act on the cancer cell. The second mechanism is that because it's an extracellular activity, that's why it downregulates the receptor activity and so degradation receptor activity, which leads to inhibit the signaling of the mutating EGFR and MET mutations, and also it also downregulate and inhibit the ligand binding. Ligand binding mutation, and also downregulate the EGFR MET expression on the tumor cells. Next slide, please. So on this background, we should know about what is now benefit and what is the dose administration. Like can you go please one backside slide? So first of all, before going the benefit of the avimentanib, that Johnson want to discuss about the dosing and administration, because it's very important of dosing and administration of the avimentanib, and because it's the fixed dose for the more. Next slide, please. For the patient who are more than 80 kg weight, and it is less for them less than 80 kg weight. It is 150 milligram for the patient who are less than 80 kg, and 40 milligram fixed dose if the patients are more than 80 kg. So basically, this is an IV administration, and the first fusion, because this is very have very more. We will discuss later on in our slides that it have most common side effect is the infusion related side effect, and infusion related side effect, and second one most common is the rash. And the infusion related side effect occur when the patient usually occur in the initial dose, so initial 1 or 2 dose. So preferably what we use in our practice, that we usually use in central line for the administration of the patient. But in these patients, when we use this first dosing in the patient, then usually we should do by the peripheral vein in the first week and second week, because you know that if you study the dosing in the patient, and sometimes some kind of infusion related reaction happen, then we can immediately stop, and the drugs which administered in the body is in the less dose. So that's why we should prefer the first and second dose by peripheral line, and later on we can subsequently weeks dosing we can do by central line. So as first dose should be as possible as the we can dilute, and so that the close monitoring should be there in this the first monitoring. So they have given the dosing schedule that in the patient in the first week you should split the dose in the 2 days. In the first day you can administer 350 milligram dose out of 1050 milligram dose, and second day we can plan 700 milligram first dosing, and later on subsequent dose 10 under 15 milligram doses we can plan. And the infusion rate, they have also mentioned that the initial infusion should be less, about 50 milligram per hour, and that we can escalate to 85 or 125 later on later dosing. And if we are planning 1400 milligram dosage in a patient of more than 80 kg weight, then first dose should be again 350, and rest dose we can administer on the next day, and later on we can increase the dose and on the same day, and also increase the infusion rate. Next slide, please. So I sent is not in proper or in proper order. So only anyhow. Okay. So as we know, the most common side effect of infusion administration in infusion related reaction, and the required pre-medication for this patient should be glucocorticoid, dexamethasone, and diphenyl and paracetamol should be given before 60 minutes and day 1 and day 8 in all patients in all cycle. And also the optional we can give the dexamethasone or acetone and ranitidine. Next slide, please. So coming to the efficacy. What is the efficacy of this drug, and which trial have shown that this drug is very important, and why we should use in this drug, and in which indication we should use. And that's why we have a hypothetical case of Mr. Anjali, 62-year-old female non-smoker, presenting to us with persistent cough, shortness of breath, and right-sided chest pain for the 3 months. She have no past any significant history except of hypertension, which is well controlled, and she have received 4 cycloplatinum based chemotherapy and also pemetrexed. And after good initial response, Mrs. Sharma started to show sign of disease progression after 4 months of the therapy. So all investigations show that there is stage 4 metastatic disease in PET scan with bone and brain mets. And bronchoscopy biopsy was again done, which shows that there is EGFR exon 29 mutation was present. PDL1, PD1 and PD1 status was negative. So how you will treat this approach? That because this is the ideal case, and this is ideal situation where now the second all TKI may be resistant because of exon 20 insertion, and that's why the amivantamab is the drug of choice for this patient. Next slide, please. So NCCN guideline have also clearly demonstrated if you found any exon EGFR exon 20 insertion, then the approval, FDA approved is though for the second line drug, but we can start amivantamab upfrontly and category 1, and also systemic treatment. And also systemic treatment is one of the option. And if the patient responding very well to systemic treatment, then again you can continue with the systemic treatment. And if patient progress no systemic, then amivantamab is the drug of choice for this patient, and this will help the patient in all kind of to control the disease. Next slide, please. So the efficacy of this amivantamab was clear efficacy and safety profile, and was clearly mentioned in Crystallis trial And especially in the study trial of phase 1 study demonstrated the efficacy and safety in a special subgroup of cohort D. And they have presented real first results in September 29 with medium follow-up duration of 9.7 months, and long-term efficacy and safety results were presented in March 23 with medium follow-up duration of 19.2 months. Next slide, please. So first, they have checked the dose escalation. What is the optimal dose for the patient in this patient? And the key objective for these patients are the patient who are metastatic unresected NSCLC and failed or ineligible for standard of care therapy, advanced and having measurable disease and having resistance to EGFR, MET mutation and amplification. So they have taken a kind of the patients who are even progressed on EGFR or progressed on immunotherapy or also have insertion 20 positive. And their key objective was to establish the recommended phase 2 dose, recommended phase 2 and safety and efficacy of the recommended phase 2 dose. And they have escalated the dose from 40 milligram to 1750 milligram. And they found that the optimal dose for less than 80 kg is that 1050 milligram, and for the patient who are overweight or obese and more than 80 kg, the optimal dose is the 1400 milligram weekly, initial weekly, and then followed by bi-weekly. And they have divided seen the effect of this dose, same dose in the different cohort, a different setup of the patients. And like a cohort 1, they have included EGFR dependent resistant, cohort 2 EGFR independent resistant, cohort 3 post EGFR, 3 third line TKI, and cohort D, which is very important and which is relevant to this study, is the cohort D, which included EGFR exon insertion 20 insertion positivity, and cohort D, momentanib plus laxative combination post EGFR TKI, cohort MET1, cohort MET2, and also patient who are progressed on eligible patient based on chemotherapy, momentanib chemotherapy. For next slide, please. So, Crystallis cohort study design, we have discussed that the optimal founded dose is 10-50 milligram, 40 milligram they have taken in this patient escalation. Next slide, please. So, next phase 2 study, they have taken the patient who and 81 population patients and all kind of patients who are, they tested this drug who are platinum based chemotherapy resistant received immuno-oncology TKI first generation, second generation, and positive in one patient. And the most demographic profile is the females predominate than male, and 60% female are female, and median age was the 62 years. Asians are dominating in 50% patients, and the rest are black and white. And smoking history and non-smokers are less or more equivalent, 53% on non-smoker and 47% on smokers. The initial time to diagnosis is 17 months. And history of brain matter, that is very important thing. History of brain metastasis was seen in 22% patient, and the patient who have brain metastasis has reduced efficacy of the avibactam because of limited brain penetration. Next slide, please. So what they have seen in that the patients who are exon insertion 20 have very good overall response in 40% who are progressed on second line or other drugs. And the best and median duration of response was seen in 11.1%, and overall response was 40%. And clinical benefit BFR was seen in 74% patient, and maximum, though there is a complete response was seen in only 4% patient, but the major chunk are in the subset of partial response and stable disease around 70%, 74% patients. So this is good drug for the exon 20 insertion patients. Next slide, please. So if we look at the subset analysis of all this demographic profile, then again, every subset is benefited from this drug with the overall response compared with the from 30% to 44%, and somewhere 54% in patient. But important point is see at the baseline, two base demographic profile where the patient have received previous immunotherapy. They are also benefited, and patient who have received previous TKIs, they are also benefited in the range of 34% to 50% overall response rate. Next slide, please. So again, now as we know, exertion 20 insertion in positivity, this drug is a good drug for insertion 20, exon 20. But again, now these are divided exertion insertion 20 divided into different genetic loops, and the gene which is helical region also shown mutation in helical region also shown overall response 100 by 100, though the patient is only one, and the clinical benefit response was seen in 100% patient. And the gene which is mutated near the loop in the 54% patient, overall response was seen in 41% patient, and clinical benefit response was seen in 70% patient. And the patient who are for loop mutation, having for loop mutation, though overall response were less, but somehow is 25% patient benefited from this drug, and clinical benefit response rate was seen in 75% patient. And the patient who are not detected by ctDNA, again, the overall response in range of 40%, and CBR is 83%. Next slide, please. So this Chrysalis trial have shown that the median progression-free survival is 8.3 months and overall 22 months seen in a patient who are progressed on first line and receiving the second line therapy in form of amamentanib. Next slide, please. If you look at the progression-free survival at 1 year, then 35%, 4% patients enjoy the progression-free survival when they are taking avantanib, and 13.7% patients are still enjoying the progression-free survival life at the age of 2 years. Period of 2 years. And overall response, if you see overall survival, then the 73% are still alive at 1 year, and at 2 years, 47% patients are alive at 2 years from the start of the dose. Next slide, please. So median overall survival was seen in 23 months, and median progression-free survival was seen in 6.9 months, patient with 9 months. Next slide, please. We discuss the amamentanib safety profile. So if we look at the safety profile, then though it's look like 99% patient have some kind of adverse event, but if you look at the grade 3 adverse are only seen in 35%, and serious adverse in 30%, and death, there is no death directly related to amamentanib was seen in these patients, 80 patients, in patients. And those discontinuation, only 4% patient discontinue the treatment because of amamentanib-related toxicity. And dose interruption was also seen in 35% patients. But somehow, only 5.5% patients show serious adverse events. So that's why this profile, though there is some kind of serious kind of adverse events seen, like of fresh, like of infusion-related reaction, but that are not serious, that not affect the amount of further treatments. Next slide, please. So if you look at the side effect, again, the EGFR related side effect like rash, paranoia was seen most commonly seen in this drug administration, and MET-related hypoalbuminemia, peripheral anemia, peripheral edema is also seen in this patient, in 18% patient. And infusion rate reaction, which is also most common, seen in 66% patient. And another side effects are less common, like dyspnea, nausea, increased ALT. But this 94% of infusion-related reactions occur within the first infusion rate and rarely impact ability to continue with the subsequent treatments. Next slide, please. So if we look at the long-term safety profile of amamentanib was consistent with all these side effects which are seen in Crystallis drug, and there is no new safety signal was seen in this were detected even in long follow-up. Next slide, please. To summarize, Crystallis trial, the amamentanib had a tolerable safety profile consistent with EGFR and MET inhibition, And treatment-related adverse event to primarily grade 1 and grade 2, and treatment-related discontinuation was seen in only 4% patient. Amendment showed robust efficacy with overall response rate of 40%, and medium response is the 11.41%. Duration of response is 11.1 per month. And clinical benefit ratio was response was seen in 47% patient, and median progression-free survival was seen in 83% patient, and overall survival 22.8 months. So, Amantine is the one of the best and first bispecific antibody which demonstrated clinical meaningful efficacy in patient with exons EGFR exon 20 insertion and NCLC. Next slide, please. So looking at to Mrs. Anjali Sharma, which we have discussed. So the best, when we discuss in the tumor board, and best treatment and looking at the side effect and considering all things, then the Mrs. Sharma was started initially amamitinib. Next slide, please. So how to mitigate we have already discussed about the side effect of immune-related reactions, but how to mitigate? What are the trial? And how we can exactly reduce the effect of infusion-related reactions. So coming to this hypothetical one more case, Mr. Pawar, a 72-year-old male, non-smoker male, diagnosed with stage 4 EGFR exon insertion 20 mutation with PDL status of more than 1%. And Mr. Pawar was started on combination of pembrolizumab plus carboplatin and pemetrexed. After initial partial response, Mr. Pawar started to show sign of disease progression after 6 months of therapy. And after discussion in the discussion in interdisciplinary tumor board, it was decided to start amendment to Mr. Pawar. But yes, we know the 66% patients have infusion-related reactions. So we have to discuss this all with our patients. So then, what will be our approach for this patient to mitigate the risk of infusion-related reaction? Next slide, please. That this because these infusion-related reactions occur in the 67% patient, but grade 3, grade 4 are very less, and only 1.1% discontinue or maintain due to IR. Next slide, please. So majority infusion reaction we know occur within the first infusion reaction. Next slide, please. So skipper study have skipper study was conducted to develop a protocol to reduce the IRR. This is the study which answered that how we should deal with the IR related reactions, infusion related reactions, and they have given a subset of prophylactic treatment. Like one arm is the dexamethasone 4 mg, second arm is the dexamethasone 8 mg BD, started from day 2 to day 1, and one dose 1 hour before. Third arm, they have given montelukast 10 mg, minus day 4, minus day 3, minus day 1, and on the day of the administration, and methotrexate from minus day 7 to day 3, 1 dose, anytime 1 dose. And they have given this standard dose to the all patient along with the larazitinib, oral larazitinib, which is also a very good brain penetration. And they just on one step, they enrolled 6 patients in each arm. If the patient have less than three patients, 50% patient, less than 50% patient infusion reaction, then these patients are qualified for the second step, where they have enrolled 10 patients and followed by 24 patients. And primary endpoint was the incidence of infusion-related reaction at the C1 day 1, the first dose, and day 1. Next slide, please. And they concluded that dexamethasone 8 mg met the primary endpoint, and administration of the dexamethasone 8 mg oral BID 2 days, 1 day, and 1 hour before IV avibactam infusion, 5 doses only, lead to approximate 3-4 reduction in IRR from 67.4% to 22%, 2.5%. Next slide, please. And again, incidence of IR and related symptom are reduced with the prophylactic regimen. And then that's why in a patient where we are fearing of this uh, infusion-related reaction, we should start this dexamethasone 8 mg 2 days before. And the most common IR-related another symptom, which are nausea, dyspnea, is also reduced, and hypertension is also reduced with this uh, pre-medication regimen. And all patients were there was no grade 3 reaction was seen in this on this in this skipper study. Next slide, please. So dexamethasone 8 milligram prophylactic effective strategy to reduce the IR with IV amendment, which reduces the IR reaction of 67% to 22.5%. Next slide, please. So Mr. Pawar, after discussing all IR reactions, we started Mr. Pawar on a momentum, and it is very well tolerated and manageable with simple protocol. IR was managed with simple protocols. Next slide, please. So, next important toxicity of fentanyl is the skin-related toxicity. Next slide. So again, one hypothetical patient, Shetty, Mr. Shetty, 37.
Just sir.
Are we?
Sir, sorry to interrupt you.
Yeah, just I will cut it short.
Yeah, please.
37-year-old may receive this momentanib after 2 cycles of chemotherapy and develop skin rash on face rash. Next slide, please. So we know that skin rash occur usually classically occur in second week to third week, and the other effect of skin and other effect toxicity, dermatological toxicity happen 6 or 7 or 8 week after later. Paranoia usually 8 to 9 week. Next slide, please. So Cocon study addressed this skin toxicity, and they used simple available medicine and compare the available medicine with the standard of care what we are using dermatological management with the prophylactic antibody in terms of minocycline and paranoia. For paranoia prophylaxis, chlorhexidine 4% on the fingernail and toenails, and skin moisturization daily, and from doxycycline week 1 to week 12, and after week 30 topical clindamycin for lotion for the scalp. Next slide, please. And they have found that this drug, next slide, please, when we apply the simple medication and simple cocktail regimen for the patient who have this kind of dermatological toxicity, and Cocoon study achieve its primary endpoint of reduction in grade 2 skin related toxicity when we use this minocycline or doxycycline with the other prophylactic agent, and there is 35% reduction in grade 2 dermatological toxicity when compared with the management of skin toxicity that we usually used. Next slide, please. So we considered amendment should be continued with prophylactic dermatological regimen to achieve the better disease control. Next slide, please. Next slide. To summarize, the Memantanib is one of the its class drug which is bispecific and inhibit ligand binding to EGFR and also effective in MET mutation, and it is the only drug which is approved for the EGFR 20 insertion patients who are progressed on even immunotherapy, chemotherapy, or any kind of other TKI, and this is only approved FDA approved drug and having with very good safety and toxicity manageable profile with prophylactic medicine for IR plus also prophylactic drugs for the dermatotoxicities. Thank you very much for giving me an opportunity to be here with you.
Yeah,
Thank you very much.
Thank you very much, Sir Justice sir, for your enlightening topic and the lecture. So thank you very much and good evening, sir. Now I would like to request Dr. Abhishek Sharma. He is the consultant medical oncologist in Goyal Hospital, Jodhpur, and he will be speaking on advanced EGFR mutation in NSCLC, a evidence-based review of the targeted therapies. Dr. Abhishek, over to you.
Yes, sir, definitely, sir. So, thank you, Asim, sir, for this opportunities, a good academic session. So, my talk on the EGFR mutation target therapy in the lung cancer. So, can someone allow to me share slides?
Yeah, sir, you can share your slide from your side.
Yeah. So is it visible to all?
Yeah, it is, sir.
Yes. So I am going to discuss the advanced stage, especially a patient with the non-small cell lung cancer with EGFR mutation. So we are just trying to review our target therapies here and what their evidences and how they benefit to our patient in day-to-day practice life. So when I discuss to the lung cancer epidemiology, globally, in 2020, account for lung cancer is the second most common cancer diagnosed in the male and third in the female. It is number one cause of the cancer-related mortality in a male and number two mortality in the females. In India, 2022 data, you can clearly see lung cancer is the fourth leading cause of cancer-related death in India and as overall fourth overall incidence as per epidemiological data. So, non-small cell lung cancer is the most common type of lung cancer we clearly see in our day-to-day practice. When I discuss about the relative survival rates that vary by stage at diagnosis, as we clearly know, there are very few patients in our practice presented to us in a stage one. It's around only 1 to 2% patient, though it was presented to the stage one. And basically those who are screened one or incidentally diagnosed. Stage 2 patient percentage is around 3 to 4%. Stage third patient is around 30%, and stage 4 patient incidence is around 55 or 70%. So mostly patient presented to the stage 4 in our presentation. And when you look for a real world survival or for the stage according to stage, you can clearly see for the stage 1 there is a good survival around 70 to 92 or 93%. When you goes down to the second stage around 60-50%, and when you look for the stage third is around 20 to 35 30% 5 year survival. When you look for the stage 4, definitely 4A is around 10%, and 4B is really none. Is some exceptional cases are still 5 year survive, but there are very few survive to the 5 year. So, uh, so definitely the stage 4 lung cancer, those who have a bulk of presentation, but still survival is not good. So definitely we have to need for some predictive biomarkers as well as some prognostic biomarkers. We all know prognostic biomarkers are the indicator of patient survival independent of treatment received because the biomarker is an indicator for the innate tumor aggressiveness, and predictive biomarker, as we all know, this is the indicator of therapeutic efficacy because there is interaction between the biomarker and the therapy on the patient's outcome. So there are the testing and genetic mutation that is available in the lung cancer. You can clearly see in this circle. There is a most common mutation we found in lung is the KRAS, and after that is EGFR is around 25% in cases, followed by some EGFR and ALK, ROS, PIK3CA, BRAF, MET, RAS, MEK. Definitely. So this is a pathways we all know. This is a mutation as we all know. But the most common mutations we see in our daily life is around EGFR mutation that is targetable. Second most is ALK, and after that ROS. So what is the testing methodology for targetable mutation in lung adenocarcinoma? EGFR, this is a approved method is a PCR or NGS. For ALK, this is approved method is FISH, and ISC also we can consider. For the same for the ROS is a approved method is FISH, and ILC also consider. But yes, for EGFR, PCR, NGS, ALCROSS we can do with the NGS also. But yes, on a FISH we can do ALCROSS mutation. Now I am going to discuss the most common mutation that is we seen in lung cancer, that is the EGFR. So EGFR driven mutation have a chain around exon 5 to exon 28. And when you look for the region 18 to 21, this is the most common tyrosine kinase where we can found the mutations. So most frequent EGFR TK sensitizing mutation is exon 19 and exon 21. In exon 18, you can clearly see G719C, S and A. In exon 90, there is a deletion. In exon 20, we all know the mechanism of the resistance. Exon 21, there is activation loop mutations. L858R is most sensitive, and second is the L86Q. So this is the mutation that is associated with some drug sensitivity. Based on the limited number of the study, the prevalence of EGFR mutation apparently appears broadly similar across the all disease states. You can clearly see in the Asian population, this is around 30 to 40% of a prevalence of EGFR mutation. In a Caucasian, is around 10 to 20%. And the stage wise, you can see is almost same in all states and as well as in some regions. That is some difference you can see in the EGFR mutation. Asians have a best, Asian has a maximum number of the EGFR mutation. So in a EGFR TKI were available in the resectable setting. similar proportion of patient may be able to benefit compared with the advanced stage. So as per NCCN, there is around uh, a good targetable mutation you can find clearly in the patient and non-small cell lung carcinoma. And yes, for those who are not non-smokers, those who are female, young, definitely they have a high chances of the targeted mutations. Those who are targetable. So what is the as we all know, EGFR is basically a cell membrane receptor, and that is help in a regulation of the cell proliferation. When EGFR is wild, pathway is on only when EGFR is bound to the receptor. When EGFR is muted, pathway is always on. There is a continuous signaling to the cell membrane followed to the other inner part of cells, and that lead to the cell proliferation followed by a development of tumor or malignancy in those patients. So, what is the current treatment options for the advanced stage cancer patients? This is a kind of algorithm you can say. One is so definitely we look for the histology. One is squamous or non-squamous, especially adenocarcinoma. Those who are EGFR mutated, we have to use the latest generation TKI in our patients. And those who are squamous pathology, or as well as those who are target negative, definitely we look for the PDL1. Those who have a high PDL1, we have option of monotherapy with the immunotherapy. Those who are between to 1 to 15, we have a combination chemo plus immunotherapy. Those who are less than or PDL1 negative, we have an option of chemotherapy with dual IO chemotherapy combination. So this is a kind of paradigm to the lung cancer patients. So now we talk about the osimertinib. That is a drug that changed the whole scenario of the EGFR mutation positive patients. As we all know, there's a initially first generation TKI, those who have a survivals is a PFS in around 6 or 7 or 8 months. Survivals is around 18 months. So after that, they are later on second or third line TKI we available. The best TKI we have seen, that is the osimertinib, is a third generation irreversible CNS active EGFR TKI that is selective for both EGFR mutated and EGFR T790M resistant mutation positive lung cancer. So this is the beauty of the osimertinib, irreversible, CNS active, and active against both selective or non-selective resistant mutations. So this is the first study, phase third study to establish the role of osimertinib in the EGFR mutated non-small cell lung cancer. So I am talking about the well-known FLORA. This is a phase third double-blind study conducted across 132 sites in 29 countries. Patient with locally advanced as well as metastatic non-small cell lung cancer included in the study. Key criteria is same as of all other lung tumors, more than 8 year, exon 19, L858 progression, and patient randomized to osimertinib versus EGFR TKI choice, alnutinib or dafitinib. One part is crossover allowed in the FLORA, and primary endpoints by the PFS, secondary endpoint by the overall response rate, duration of response, overall survival, safety, and all other meters are there, and they are stratified according to exon 19 deletion, L85R mutation, and according to the races, they are stratified in this study. Baseline characteristic in the FLORA study is well matched. You can clearly see for the sex, age, race, smoking status, CNS, WHO, performance status, overall disease classification, histology, EGFR mutation at randomization. There is a well match in a both arm, osimertinib compared to the other EGFR TKI. And the primary endpoint of the PFS by investigator assessment, you can clearly see there is a 18-month median PFS in osimertinib when compared to the other TKI is around 10.2 months for a first generation TKI, and clearly see around 18-month or 2 year PFS. Yes, osimertinib reduced the risk of progression of death by 54% when you compare to the standard EGFR TKI. So there is a clear-cut benefit in the median PFS as well as 2 year and 5 year PFS. And when we look for the efficacy in all subgroups, yes, you can clearly see the forest plot in favor of osimertinib. So consist benefit of the osimertinib seen when you compare to the first generation TKI was seen all across of the pre-specified subgroup. Now we talk about the efficacy objective response rate. This is a important for definitely for our patient. This is very important part because patient is comes to you heavy symptomatic patients. So definitely response is definitely a concern for us. Those who have a good response, good relief in the symptoms, and definitely patient improve the quality of life. So response rate you clearly see this is quite good with the Uh, Osmatrip, when they compare with the other parts, just definitely is good. Stable disease more than 6 weeks. Progression part is very low, is only one compared to the standard of care. And duration of response, you can see in this curve, there is quite good with the Osmatrip when you compare with the first generation TKI. Now move to the final part of this Flora overall survival analysis. At the 58% maturity, you can clearly see the final analysis of OS demonstrate a clinically meaningful and statistically significant improvement with the osmotive when compared with the first generation EGFR TKI. So the overall survival is around 30, almost 39 months compared with the 30-month or 31-month with the standard TKI. So yes, there's a clear cut OS benefit. There is a well separation of curve. You can clearly see with the initial part of curve to the till, there is a good separation as well as hazard ratio is good and p value is significant. So overall survival, PFS, a good response rate we seen with the osmantinib. When we look for the adverse event summary, definitely osmantinib. Most common side effect we seen is that rashes, diarrhea, other nail fag, dry skin, paranoia, stomatitis, anorexia, cough, and some cases are transaminitis, and some very rare cases of the myelosuppression as well as neutropenia, thrombocytopenia we can see in our patients. But when you compare with the other TKIs in this study, yes, there is a all more or less osmanthreib has a more safer with the comparator where the GI toxicity is quite high, some skin toxicity is quite high when compared with the osmanthreib. So overall, there is a safety is quite good with the osmanthreib. When you look for the death due to any adverse event, that is around 2% is with the osmatrip, while 3.6% with the other TKIs. When you look for the leading discontinuation of treatment, there is a 13% with osmatrip and 18% with the other part. So definitely death and discontinuation treatment is quite low with the osmatrip when compared with the standard treatment choice for the patient. So my summary for the Flora 2, yes, osmatrip reduced in resulted in highly statistically significant and clinically meaningful improvement in the PFS over to the standard of care. Hazard ratio is 0.46, 0.54 per risk reduction, progression or death. So consistent benefits seen in the all subgroups with or without CNS meds, doubling of the duration of response with osmatinib, and significant and clinically meaningful improvement in the CNS PFS over the standard of care with hazard ratio zero point 0.4 and final analysis of the OS results showing promising survival trend favoring osmotic versus standard care, hazard ratio zero point 0.7, PFS and OS seen across all subgroup is benefit seen in same. Comparable safety profile with the other TKI is quite good as a safety parameter. So osmantinib is a standard of care in the first line treatment of EGFR lung cancer, as we all know. Once the osmantinib is there, everyone choices osmantinib. So now look for the what is the most important part when patient present to the brain metastasis, CNS efficacy for the osmantinib. CNS metastases occur at higher rates in those patients, those who have a EGFR mutation when compared with the wild type EGFR. You can see patient, those who having EGFR mutation at the initial diagnosis, brain met chances around 90 to 24% when compared with the EGFR wild is around only 10 to 13%. And during follow-up, almost 44% develop brain mets when compared to the wild EGFR is almost half. Leptomeningeal mets definitely 9%, 1.7%. So yes, CNS mets chances high in the EGFR mutation patients. So definitely we look for the CNS activity of the all EGFR sensitive TKIs. So this is the CNS activity, PFS in the patient with or without CNS meds at the baseline. You can clearly see osmatinib with CNS med baseline, BFS around 15 months versus 9 months. Without CNS meds, definitely clear is 9 months versus 10 months. So osmatinib benefit was consistent patient with or without CNS meds. Fewer CNS progression events were observed with the osmatinib is only 6%, when the other standard TKI is around 15%. So CNS activity, CNS PFS in CNS full analysis set, you can clearly see there is not reached in osmantinib while 13% in the standard of care. So osmantinib showing a good CNS activity, showing in the good PFS improvement in the patients, those who have a CNS baseline as well as doublet during the treatments. So there is a first line some TKIs also available. One is most is available is documentary. When we talk about the financial part, so yes, we always look for what is your choice between the osmometry and documentary. So definitely doing a cross comparison trial is not a good option But yes, when we just see number of PFS months, number of other data with the Archer and Flora, you can see the when you read the curve, initial 6 month in our curve, there is no separation of curve, but there is an immediate separation in the Flora. Hazard ratio is 0.46. As we all know, 18 month versus 10 month is the median PFS, where the Indocuma is around 9 month versus 14 month with hazard ratio in zero point 0.9. And in Archer, OS not statistically significant since the formal comparison of overall response rate was not statistically significant based on the this study hierarchical testing rules. So no statistically significant ORR benefit, no OS statistically significant in the ARCR, but in the FLORA, there is a statistically and clinically meaningful improvement in the OS as well as PFS as well as overall survival. So yes, first line choice, our choice should be osimertinib, and our in a clinical practice, most are using osimertinib as a their first choice in our patients. And overall survival, yes, definitely I already discussed patients 13.6 versus 39 versus 31 month in standard versus Osmantrib. So this is the same we already discussed. In Archer 1050 for documentary p-value could not be given to the OS. This is yeah. So definitely this style is a hierarchically stratified statistical design and did not mean the significant ORR and p-value did not translate to the overall survival. So one more part is that osimertinib versus afitinib. Definitely, there is no head-to-head comparison with the osimertinib versus afatinib. Yes, we all know about the afatinib Lux lung trial. We all know there is a median PFS in this afatinib in a Lux lung is around 11 months. When you compare to the toxicity part, yes, afatinib is not so as a good tolerable drug when compared with the osimertinib in the as clinical experience. But yes, PFS benefit when compared with the Jeffinib is present with the afatinib. And when the overall survival, yes, there is no survival advantage seen when in the Lux lung when they compare afatinib with the versus Jeffinib in their part. And as well as lung trial, their overall survival for the pre-specified subgroup of the exon 19 deletion as well as L858R showed similar OS trend. So median OS with afatinib versus Zemtinib with the patient with the same mutations is almost same. So when you say look for afatinib versus Zephyrus, there is no clear benefit of the OS. There's only benefit of PFS that is not so high, not so great. So definitely afatinib, when you compare it with the afatinib and osimertinib, there's no there is no head-to-head trial, but the part of PFS, part of OS, and other part of safety, definitely. Osimertinib safety profile compared to oral TKI is quite good. So this is a top choice of the osimertinib chosen over the documentinib or afatinib. And Flora study was also a sequencing study because they allowed the crossover in the comparator arm. First there is a TKI, then they cross over to the osimertinib, and so first line
Sorry,
osimertinib had a
Dr.
better.
Abhishek.
Yes,
Dr.
sir.
Sorry, yeah, I would like to interrupt you. Please conclude
Yes, sir. Definitely. Okay.
in the interest
So
of we are running.
yes, yes, sir. Definitely. I'm concluding in the next 1 minute. So this is about basically EGFR TKI Flora. We already discussed about the osimertinib in our patients. So my conclusion: this is the first time to evaluation of EGFR TKI. Osimertinib translate PFS to a significant OS benefit. OS is median PFS, we already discussed. CNS activity, we all know about the osimertinib as well when compared to the standard TKI and fewer less side effects. So osimertinib is a choice. Right now we have a Flora 2 also. Osimertinib with the chemotherapy that is showing a best PFS as well overall response rate. So you can choose your patient, those who are major positive patients. Thank you, sir.
Thank you, Dr. Abhishek.
Yes,
So
sir.
I would like to share today's event. Uh, I had an interview in the Doordarshan today. So after the interview, we were meeting with the CEO of the this one Doordarshan Jaipur. So he was telling his close relative is positive for EGFR, and she is taking in the stage 4 osimertinib for since last 10 years. So you can
Well, sir.
imagine the impact of the newer drugs. And
Yes, sir. Definitely.
I would like to invite our next speaker, Dr. Lalit Sharma. He is the consultant medical oncologist in Manipal Hospital, Jaipur. My good friend, and he will be speaking on vision for MET 14 skipping mutations in the patient of NSCLC. So, Dr. Lalit Sharma.
Good evening, sir. And at the outset, let me thank you for organizing this yet another academic feast for all of us and giving me an opportunity to share my views over here. So, the job cut out for me is discussing the metaxon 14 skipping mutation in the non small cell carcinoma patients. Uh, so, are my slides visible?
Yeah, sir, they are.
Yes, sir.
So, in the current talk, what we are going to do is we are going to see what's the importance of testing metaxon 14 skipping mutations in patients with non-small cell lung carcinoma, and what are the current insights into the management of these patients, and what are the current treatment guidelines for these patients. Why we are talking in depth regarding lung cancer is because it is a worldwide menace, and there is a large number of cases globally. Around 14% of the cases are of lung cancer, and in males, and around 8% in the females. Though in India, this percentage seems to be rather small, but most of us would agree that this is definitely tip of the iceberg, and it is an underreporting. Carcinoma is one of the deadliest um, malignancy which is affecting the Indian population. Now, as the science is advancing, we are moving more towards precision oncology. Gone are the days when we used to treat lung carcinoma, all lung carcinomas as garden variety and give them platinum based doublets. Now we are moving towards molecular profiling, and currently molecular testing is of paramount importance in identifying patients with non-squamous non-small cell carcinoma who may benefit from the targeted therapies. So this is the reason why the current clinical practice guidelines are kind of suggesting that biomarker testing is being done upfront. Larger the panel, the better, but at least mutations against which targeted therapies are available definitely need to be assessed. And if the logistics do allow, along with that, markers for immuno oncology drugs should also be conducted. More and more data is now accumulating, which suggests that during these broad-based panels, we should be including MET exon 14 skipping mutations with advanced non-small cell lung carcinoma patients. So most of us do face this question while ordering these particular molecular panels. So how broad it should be, what all mutations should be covered in that. Gradually the number of mutations, appropriate number of mutations, is gradually increasing. Thankfully, as the science is advancing and NGS is becoming a commonplace, the costs of running these particular panels are also reducing, and we are able to kind of include more and more targetable mutations in these panels. uh, as far as my personal practice goes, most of us would agree that it's better to have a larger panel so that there further down the lane there are no issues regarding the availability of the tissue, and we could kind of identify more and more patients eligible for targeted therapies. So then comes the question of what particular tissue we would like to choose for running these mutations, especially for metaxon 14 mutations. The gold standard definitely remains tissue biopsy, but patients wherein tissue biopsy is not available or re-biopsy is kind of questionable. Most of the times we find it challenging to do a biopsy again if the tissue is not in appropriate quantity, even if at times wherein the patient has progressed and we wish to kind of reprofile the patient to look for any new mutations, it becomes very difficult, and only small proportion of patients would agree for rebiopsy. In those situations, though, liquid biopsy can very well be considered. The advantages with liquid biopsy are that the accessibility is quite high. It is a non-invasive, simple blood draw, but there are no risk of complication. Sensitivity with these biopsies are gradually kind of improving as more and more science is advancing, but targeted collection is not possible. And as far as tissue biopsy goes, accessibility though is moderate, but and the kind of procedure is usually invasive and risk of complications are there. But the most important thing for which we are running these tests, the sensitivity is higher than liquid biopsy, and the targeted collection is only possible with tissue biopsy. So it might not be suitable for all patients, but wherever possible, we should be looking for tissue biopsy, as it is the current gold standard for identifying most of the targetable mutation, and so it goes for MET exon 14 mutations also. So currently, what is if we look at the current data or the recommendations, what are the various options available to us, and in what particular situations would we like to choose these particular options? First and foremost is the platinum doublet, then are immunotherapies either in combination with chemotherapy or standalone, or immunotherapy combinations, or metexon TKIs in patients who are harboring metexon mutations. That is the so we have now decent data to suggest that in patients with MET exon 14 skipping mutations, MET inhibitors significantly improve the overall survival compared with the chemotherapy, to the tunes of overall survival of 8.1 months with chemotherapy vis-a-vis MET inhibitors giving us 24.6 months of overall survival. And mind you, this is with lesser toxicity and improved quality of life. Another interesting fact with metaexon 14 skipping mutations is that these patients tend to express PDL1 in greater proportions, but unfortunately, the IOs are not working that well in these particular patients. So, if we compare metaexon met directed TKIs versus IO monotherapy, the median real world PFS is usually 15.9 months with tepotinib versus 3.4 months with monotherapy. If we combine chemotherapy along with IO, this kind of PFS does improve, but still remains subpar. And even in this setting, it is 15.9 months with the TKI versus 7.8 months with the IO chemotherapy combination. And there is a limited response to immunotherapy, and the overall response rate in metexon 14 patients is also less as compared to the other patient profiles. Now, immunotherapy providing very limited benefit in these patients, and should not be considered as the first line, especially if we are considering for monotherapy. This is also reflected in our current clinical guidelines. NCCN currently gives the preferred category indication to metexon 14 skipping mutation setting the TKIs, either tepotinib or capmatinib, and in some situations crizotinib can very well be considered. Similar is the scenario with ESMO guidelines, wherein they do acknowledge that both tepotinib and capmatinib have demonstrated clinically meaningful efficacy in this particular setting. So Vision was the first, was one of the studies which kind of examined. It was a large study. It was the first clinical trial which kind of looked into MET inhibition and is prospectively enrolled patients based on both liquid and the tissue biopsy, which gives us more confidence in kind of putting patients who have turned up positive on liquid biopsy rather than tissue samples were scanned. Another important thing is this particular trial had a significant chunk of elderly patients, that is more than 70 years. Around 30% of patients were Asian patients, giving us more confidence that this particular data would also reflect in our day-to-day practice also. So it was basically a phase 2 trial wherein patients harboring MET exon 14 skipping mutation was started on Tepmetco 450 milligram per hour per day. The primary endpoint of the study was overall response rate, and the secondary endpoints were duration of response, overall survival, progression-free survival, and the safety profile of the drug. As far as the demographics go, majority of the patients were elderly. There were almost equal number of both the genders. Around one third of the population was Asian, and there was a decent chunk of smokers, that is around 53%, almost half of them. There was majority of the patients were adenocarcinoma, with around 7 to 10% having squamous cell carcinoma. Around one fifth of the patients had a brain metastasis at the baseline. So a decent number, around 53% were more than 75 years, and we have already discussed this demographics. Around 36% of the patients were diagnosed based on liquid biopsy alone, whereas 42% were diagnosed based on tissue biopsy alone. 21% had both liquid and tissue samples available. As per the study, there was a significant overall response rate of 58%, with a median duration of response of staggering 26.4 months, median progression-free survival of 15.9 months, and median overall survival of 29.7 months. Around 90% of the patients experienced tumor shrinkage with Tepmetco. And Tepmetco also demonstrated robust and lasting efficacy in previously treated patients also. Though it was not as robust as in the frontline setting, still the overall response rate was almost 50%, with a median duration of response was 10 months, and a median progression-free survival of 11.5 months, and a median overall survival of 20.4 months. So the efficacy was robust and durable in treatment-naive Asian patients and previously treated Asian patients also. As far as the overall response rate goes, it was even better in the Asian patients, with around 64% response rate, duration of response of around 20.7 months, PFS of 16.5 months, and an overall response rate of 32.7 months, which is quite impressive in the first line setting. Even in the second line setting, the advantage was maintained, though the magnitude was slightly lower, with an overall response rate of 50% and duration of response of 10.8 months, PFS of 12.1 months, and very decent overall survival of 23.7 months. So another question which comes to our mind is how to handle the patients who are presenting with upfront brain metastasis. Most of us would agree that around, say, one fifth to a quarter of patients unfortunately turn up with brain metastasis. Tepmetco basically showed a very significant improvement in the intracranial disease controls to the tunes of 88%, and 66% showed significant intracranial response, with a 20.9 months of the intracranial median PFS, and the intracranial median duration of response was not achieved at the time of publishing of the results. The significant response can very well be seen in the depicted imagings which we can see, wherein almost a complete CR can be seen in the brain metastatic lesions even at week 36 of the therapy. So another question which comes to our mind is, which MET exon inhibitor do we consider? Now, unfortunately, we do not have any head-on trial for both the available options, and that is usually the case with most of the kind of targeted therapies. Cross-trial comparisons are usually not advisable, but due to the lack of data, most of the times we end up doing these. If we compare with a pinch of salt of both the trials which kind of evaluated Tepmetco and capmatinib, the Vision trial had a significantly kind of greater number of patients enrolled, giving more potency to the data. Brain penetration was significantly more with Tepmetco, and tumor shrinkage was seen in 86% patients in the TEPMETCO trial, and with a 71.4% intracranial control. Moreover, the dosing is also considered to be slightly more kind of simpler, and dose reduction is also considered to be slightly more simpler with TEPMETCO as compared to capmatinib, wherein in case of dose reduction, we have to go through a cumbersome process of replacing all the tablets from 200 milligram to 150 milligram, whereas in the TEPMETCO scenario, the only thing which we have to do is reduce the number of tablets from 2 to 1 while de-escalating the therapy. Efficacy wise, again, I would not go into the details because it's a cross trial comparison, but there is one notion which does come while going through this data, that there might be a slight preponderance towards more efficacy with TEPMETCO. Still, I would not advise anyone to take this cross trial comparison to be the basis for their choosing of the first line therapy. So how important is dosing convenience for one has to be considered. When we compare both the drugs, the T half is more with significantly more with TEPMETCO, and there is a simpler daisy dosing with TEPMETCO in the sense that 225 milligram tablets have to be taken, and that too once a day. Whereas with capmatinib, we have the drug in two different kind of strength, that is 200 milligram and 150 milligram, and these have to be taken 2 tablets twice a day, making it 4 tablets a day. And as we did see that most of these patients are elderly and usually have a very high kind of pill burden already, so this might add to the pill burden. Moreover, when the dose reduction has to be done with TEPMETCO, it's rather simple, switching from 2 tablets to just 1 tablet. Whereas with capmatinib, first we'll have to change the doses in the form that initially the patient is taking say 300 milligram in the morning and evening, which is 2 tablets, 150 milligram in the morning and 2 tablets in the evening. We'll have to switch it to 200 milligram, 1 tablet in the morning and one in the evening, which again raises the question of what to do with the rest of the 150 milligram tablets, though there are other ways to get around it, but it gets slightly messy. So then comes the safety profile, and we would wish to see what are the various treatment related adverse events with these MET inhibitors. The most common treatment related effect, and probably the class effect of MET inhibitors, is edema. It is seen in majority of the patients to the tunes of say around 60% plus patients, but a grade 3 or more is seen in anywhere 10 to 15% patients, both with TEPMETCO and capmatinib. The nausea is the another common side effect, more common with capmatinib than TEPMETCO. Creatinine clearance is also an issue, almost in the similar tunes with both the molecules. Though thankfully, as far as the hepatic profile goes, TEPMETCO and capmatinib both seem to be more uh, causing lesser hepatic toxicity, more so with capmatinib. Their ALT alterations can occur with TEPMETCO. So, how to manage edema, which is a class effect, and we are going to see it with almost all MET inhibitors. The basic pathology, though it's not clear, but edema can be because of inhibition of MET in the vascular and lymphatic endothelial tissue, leading to extravasation of intravascular fluid. And the usual measures which we need to use or preempt edema while using these medications, and the preventive measures should include limb elevation and exercise, compression garments, lymphatic massage, diuretics such as furosemide, and regular monitorings. Even despite this, if the edema does occur, we can opt for dose reductions or interruptions, especially if the edema is quite troublesome and it is grade 3 or more. Permanent discontinuation might be considered or should be considered for grade 4 events. Dose reductions thankfully do not affect the efficacy of Tepmetco and can very well be considered.
Lalit
Thank
sir,
you.
sorry to interrupt. Just wanted to request to conclude your talk, sir.
Real world evidence is there that even if we reduce the doses, the efficacy is still maintained, and simple conservative measures can be effective in reducing the side effects. So, to conclude, why we could consider tepotinib in metexon skipping mutations is one, there is a robust kind of recommendation from the guidelines. Vision study does give us the largest study which did study this molecule in patients with both tissue and liquid biopsy in first line and the second line setting. In the first line treatment, 90% patient experienced tumor shrinkage with a impressive median PFS of 15.9 months and overall survival of 29.7 months. In the kind of difficult setting of brain metastasis, also there was a decent brain penetration and improvement of 25%. 25% brain penetration was there, and around more than 88% showed intracranial disease control. Dosing convenience and safety is also there, which also helps us. So I would skip the case study in the interest of time, and I would like to hand over the proceeding to the organizers. Thank you for the opportunity again.
Yeah, thank you very much, Dr. Lalit, for your flawless talk. And it was a very important topic. And actually, nowadays, yes, we are doing NGS more and more patient of the NSCLC. We are getting this mutation quite frequently. And targeting with this drug is we all know it's an amazing experience. With the minimum side effect, patient will get the good benefit in their clinical scenario. So thank you very much for your talk. And now I would like to request our next speaker, Dr. Tarachand Gupta. He is my colleague and my partner in the tea, coffee, and day-to-day life in the Bhagwan Mahavir Cancer Hospital. He is the consultant medical oncologist there, and he will be speaking on new era, uh, integrating immunotherapy into the limited stage small cell lung cancer management. So over to you, Dr. Tarachand.
Thank you, boss, for a kind introduction. And I think I share my slides. Just a minute. I think my slides are visible.
Yeah, sir, it is visible. Can you make it full screen, sir?
Yes, I am making it. We are talking today about the untouched topic and less talkable topic, that is small cell lung cancer, limited stage.
Bola.
And now immunotherapy has also entered in this segment also.
Double.
So, small cell lung cancer is an aggressive cancer with a poor
Sorry,
prognosis. Yeah,
9:30.
who is there? Hello? Yeah, should I continue?
Yes, sir.
Tarachand.
Dhruv, mute yourself.
So aggressive cancer with a poor prognosis. Traditional treatment is the concurrent chemoradiotherapy with a prophylactic cranial radiation. Median overall survival is still 25 to 30 months in this segment, and 5-year survival is 29% to 34%. So this is an urgent need for new therapies like immunotherapy. So what is the rationale of immunotherapy in limited stage small cell lung cancer? As we know, immunotherapy works better whenever it finds a difficult tumor. That means the higher tumor mutation burden. Higher the tumor mutation burden, higher the chances of immunotherapy to work. And who is the better cancer than small cell lung cancer, which is having a higher tumor mutation burden? So it is there. So small cell lung cancer has the immune evasive biology also with immunotherapy success in extensive stage small cell lung cancer. We have already seen there are 2-3 drugs are already approved. So this is the diagram which is showing that how the mutation, how many mutations are there, including the tumor infiltrating effect T cells, tumor-associated macrophages, MDSC, peripheral effector T cells, cancer cells, etc., etc. So this is the current standard of treatment we discussed in the last slide. So the trials which investigated immunotherapy in local limited stage small cell lung cancer, the most important is the Adriatic trial, durvalumab plus minus tremelimab post CTRT, Keynote 604, that is pembrolizumab plus CRT, AFT16, atezolizumab plus CRT in local limited stage small cell lung cancer under trial. So mechanism of action of ICS is very simple. Whenever the tumor is there, it blocks the T cells by the PD, and that's why it inhibiting the immune action of the body, and that's why the tumor grows. So what does the immune checkpoint inhibitors do? They come in between these two, that means tumor cells and the T cells, and open that blockade, and the immune cells are free to act. And CTLA4 also blockade enhances T cell priming and checkpoint inhibitors potential anti-tumor immunity. As this is shown in diagram, we can see easily. So the highlighted topic is Adriatic trial, limited stage small cell lung cancer, which is now a talk of the town, and it is even NCCN updated also. So if we go into the background, that only few advances of what treatment are there in the last decade. Pacific trial shows the consolidation durvalumab after the concurrent chemoradiation in unresectable stage 3 non-small cell lung cancer provide the PFS and OS benefits. So this gave the rationale. And even in small cell lung cancer extensive disease, durvalumab along with the EP regimen is giving a cutting edge to the treatment lines. Adriatic phase 3 trial assessed the durvalumab plus minus tremelimab as consolidation treatment for patients with LS-SCLC who had not progressed after CTRT. So current analysis report results for durvalumab versus placebo as a first interim analysis. Right. This is a multi-center international randomized double-blind phase 3 trial stratified by the disease stage 1, 2, or 3 and PCI, yes or no. This means no progression after the concurrent chemoradiation. PCI allowed prior to randomization. And CCRT and PCI completed 40 days prior to the randomization. WHO performance status 0 to 1. So 3 to 4 cycles of platinum and etoposide and RT 60 to 66 gray over 6 weeks or 45 gray in a VD dose over 3 weeks. RT must start no later than end of cycle 2 of chemotherapy. So patients were randomized durvalumab only 1500 milligram 4 weekly, placebo, and third arm was a durvalumab plus tremelimumab with a 75 milligram to 4 weeks tremelimumab into 4 doses, then 1500 milligram weekly only durvalumab. Primary endpoint was PFS by BICR, and secondary endpoints was PFS by BICR as per RECIST V1.1 and OS for durvalumab plus tremelimumab versus placebo. And the treatment was continued until the investigator determined progression or intolerable toxicity or 24 months. Here, the durvalumab goes beyond 1 year, not like an SCLC. So these were the patient characteristics. Durvalumab versus placebo, that median age is 62. In both arms, most of the patients were male because this small cell lung cancer mainly occurs in smokers. And Asian population is nearby equal to white and others, around 49.6%. In both arm, other arm it is 45. Performance status was good. Smoking status, if we see that around 90% of patients were a smoker. Out of these, former smokers were 67 and 23 were the current smokers. And disease stage as most of the patients were stage 3, 87.5. As we know that usually the small cell lung cancer diagnosed at advanced stage. Prior chemotherapy regimens cisplatin etoposide in 65% and etoposide carboplatin in 34-35%. Prior radiation schedule once daily 73.9 versus 70% and twice daily was allowed in 26 or 29%. Best response to prior concurrent chemoradiotherapy, CR was achieved in around 12% patients in both arms. Partial response was also around 72 to 75%. And prior PCI was allowed in 53% patients and 46% patients did not receive PCI. And there's a good payoff. So efficacy outcome is overall survival. It is around events were occur around 115 patients total and 43.6% patients and 54.9% events were occurred in placebo arm. Hazard ratio for 4-month OS was 68 versus 58.5 and 36-month overall survival was 56.5 versus 47.6%. PFS was around 52.7 events occurred in the durvalumab arm and 63.5 placebo. Median PFS 16.6 versus 9.2 months. It's quite longer. Hazard ratio 18-month PFS is 48.8 versus 36.1 and 24-month PFS is 46 versus 34.2%. As per the subgroup analysis, for the age less than 65, it is around 0.76 and for 65 more than 65, it is 0.70. So this is quite an elderly hazard ratio is very good. Where the male and female both are showing good. Males are slightly better in position, and Asians are also showing same results as per the white. And the poor good performance status patients were having good hazard ratio of 0.55, and time from end of CCR to the randomization was less than 14 days. If it was then, it is the best time to start durvalumab, and after 28 days, it is of little bit benefit only. So keep in mind that after the 1 month, durvalumab, it is as good as no drug. Prior chemotherapy regimen, say etoposide cisplatin 0.56, or if you are using carboplatin, here again you can see that cisplatin is a good radiosensitizer or better than carboplatin. That's why hazard ratio is better here. Prior radiation schedule once daily, twice daily, both are same. As per if the patients were in CR, then hazard ratio was 0.9, partial response 0.76, and to stable disease it is 0.54. It is quite surprising. Prior PCI, it is 0.75 versus 0.71. For the safety analysis, any toxicity, it is around 94.3% in durvalumab arm and 88 versus placebo. Maximum grade 3-4 events were same in both arms, and serious events were 25 versus 30%, and treatment was discontinued in 16.4% patients in durvalumab arm, and death was because of the treatment related, it was only 0.8%. And this is the pneumonitis or radiation pneumonitis maximum grade 3-4 was 3.1 versus 2.6, and leading to death only one patient, and leading to treatment discontinuation is around 8.8. And most frequent adverse effects in durvalumab, it is 22.9 versus 23.4. So pneumonitis was same in both arms. That is, I think, radiation-induced pneumonitis. Hypothyroidism was more common in durvalumab arm. Cough and pruritus was also more common. And nausea, dizziness, and fatigue nearby same. And other are the diarrhea and pneumonia. And rest are nearby same in both arms. So investigators' conclusion for the ADRIATIC trial was statistically significant and clinically meaningful overall survival and PFS improvement observed with the durvalumab as consolidation therapy following concurrent chemoradiotherapy versus placebo in patients with limited stage small cell lung cancer. Median OS was 55.9 months with durvalumab versus 33.4 months with a placebo, hazard ratio of 0.73. Median PFS was 16.6 versus 9.2 months. Safety profile of durvalumab was consistent with that reported previously with no new new signals. So investigator concluded that consolidation therapy with durvalumab is a new standard of care for patients with ALS SCLC after CTRT. So challenges in integrating immunotherapy is optimum timing, risk of NS immune-related toxicities, and lack of predictive biomarker. So other biomarkers and predictive indicators are PD-L1 expression, variable and inconsistent predictive value. Tumor mutation burden may be promising but not standardized. Circulating tumor DNA emerging tool for response monitoring. For the future direction in SCLC, it is combining IO with novel agents like PARP inhibitor that may be possible in near future, personalized IO strategy using molecular profiling, and clinical trials incorporating adaptive radiation. So to conclude, immunotherapy offers new hope in limited stage small cell lung cancer. Integration with CTRT is under active research. Ongoing trials may redefine treatment paradigm. So these are my references. Thank you. I'm happy to answer if there is any question.
Thank you, Dr. Tarachan, for your nice talk and extensive talk. So, and as we are running short of time, so we'll be taking in the this next coming session, which is the panel discussion. And for that,
Technical team, kindly close the recording.
Hawat is a consultant medical oncologist in and bone marrow transplant specialist in Bhagwan Mahavir Cancer Hospital, Jaipur. And nowadays, Dr. Prakash Singh Shekhawat is doing CAR T cell also. So he will be speaking on a very important topic of teclistamab, a promising bispecific antibody for triple line exposed myeloma. So you can say the resistant myeloma. So Dr. Prakash, over to you.
Thank you, sir. So, is my screen visible to all of you?
Yeah. You can share the slides. So suddenly we drop into the hematology portfolio. so it's a kind of like it's a crash landing on the important topic.
Yes.
This topic was also very burning, and now it's a good topic.
So I would like to be in a big hurry and we'll skip some of the data. So we are discussing about teclistamab. It's a BiTE, we all know. And why are we discussing it now? Is the slide changing?
No.
Now?
No, it's not changing. Your computer screen is visible to us, but not the presentation.
Okay, so which slide we can see? Dhruv, which slide is visible?
Sir, we just see the screen. We are not able to see any slides, sir.
Okay, then you please share it from your side. No?
Sure, just a moment.
Dhruv, I would request you please be there, and as he asked.
Yeah. Sir, my slides are visible?
Yes.
I can see. So please change to next slide. So why are we discussing it? Because multiple myeloma is of the second most common hemat malignancy, and we see a lot of patients in myeloma compared to Western world, and our patients present early. So unlike 60s and 70s in there, we are seeing patients in 40s also nowadays. So the early they present, the early they relapses, and they have a lot of life remaining to tackle and to deal with this and to fight the disease. So we know when a new patient comes to us of a myeloma, almost all try to take the treatment with whatever they can afford and that suits their body and pocket. But eventually with every relapse, almost 30 to 35% patients drop out. So the first line patient will be taking 95% of treatment. Second line, it is approx 60, then it's close to 35, then 15. So ultimately, the patient becomes more and more relapse and more refractory. He is not going to respond, and many of them will not take treatment. So almost 80% patients become triple class refractory. What are the classes? The most common class first is steroid, then a proteasome inhibitor, then a amide, then a CD34 and alkylator. So we usually take these 5 classes, of which a PI, amide and a CD34 antibody is very important. So if someone is exposed to all these 3 and is refractory, then it will make our life also hell and it will make patient's life also hell. So we need to act swifter. Next slide. So we can see in this that the all myeloma ultimately come out from MGUS or smoldering, and with each therapy, the first one is best one. If you can have a good one, then the chances of remission is more. With as the time passes by, there is definitely going to be a relapse, and the CR2 is going to be shorter, CR3 is going to be even shorter, and CR4 will be even softer. So it's very tough to achieve a CR4 actually in myeloma. Next slide. So the drug which we are discussing today is teclistamab. It's a bispecific antibody, BCMA and CD3. Because it's a BiTE, then a T-cell engager is necessary. And it has been approved by NCCN and it has been approved by International Myeloma Working Group, both in multiple myeloma and later line. Next slide. So we have many drugs, many new drugs, and you name it, we have it. Almost all classes of drugs, starting from our routine chemo, then the PI, then MABs, then the BiTEs, and then CAR-T. So we have many drugs. When we are on the extreme right, the rescue part, where the disease is relapsing again and again, and it has become extremely refractory, then many of these drugs also doesn't work, including the newest one. So on that extreme right, we have daratumumab, we have carfilzomib, we have selinexor. Selinexor is absolutely nonsense kind of drug. Then we have BiTEs, belantamab, teclistamab, and CAR-Ts also. Next slide. So these are the different trials and where the teclistamab study is going on. Next slide. So what is teclistamab? As I already said, it's a BiTE. So one part will bind to the tumor cell, which is a myeloma cell, B cell maturing antigen, and another part will bind to a CD3 of a T cell, and it will bring them close to each other, and the T cell will ultimately try to kill the tumor cell, like it happens in all BiTE. So it's a duo body platform, which we know. Next slide. So teclistamab, when it was tried in Majestic 1 trial, it was used as a single therapy. So monotherapy, it's most common use as a monotherapy. And teclistamab was studied in step-up doses. So initially they have gone with 0.06 mg per kg. And then they have increased the dose by 5 times. Then they have again increased the dose by 5 times. So in each successor, they have increased to ultimately 1.5 mg per kg is the maintenance dose, and that has to be maintained for the study period. So because it is known to have a serious side effect of CRS and ICANS, that's why the initial dose was very low. If your subject is not having any significant toxicities, you increase the dose. You can increase the second step-up dose in 2 to 4 days, even at the end of 1 week, then the maintenance dose, and then weekly, till your patient have achieved CR. If it's achieved CR, you can reduce it to every 2 weekly and even every monthly also. Next. So we are using teclistamab. So because of concern of anaphylactic reactions and CRS, we are using pre-medication, like it's very common thing we use in all our patients. So in first and second dose, we can use, if the patient doesn't have any CRS or anaphylaxis, then from third, fourth cycle, maintenance doses, we can omit these steroid and AVIL and PCM. Next slide. So Majestic 1 is the first trial. The first part was phase 1, phase 2 trial, and the second part was phase 3 trial. Next slide. So they have included many patients who were at least triple refractory, and they did 2:1 randomization to receive teclistamab versus a placebo. And in this trial, they have shown that the teclistamab has worked remarkably well, which will come to in next slide. The primary endpoint was overall response rate, and secondary endpoint was duration of response, then achievement of different degree of responses like CR, stringent CR, and MRD status. MRD was checked by NGS, not by flow. Next slide. So what they have done, that they have included many patients, and we know when the subjects are more than 3-line refractory, then many of them will be extramedullary myelomas also, which are very terrible, and many of them were high-risk cytogenetics also. So ISS3 was in almost 25% of cases, and mostly we have seen that because of the study design, all patients were triple class exposed, and almost 70% patients were penta exposed, means they don't have anything left on the earth. So they have seen everything. So it was a very resistant kind of population which we are included. Next slide. So we can see that almost 63% patient have achieved overall response, and almost close to 46% have achieved a CR in this almost very triple class refractory population. And the patient we have followed for 2.5 years, and after a period of 2.5 years, they have seen that those who have achieved CR, they continue to maintain a deeper and durable response even in their later part. Next slide. So this is same that they have maintained a deep response. Next. So locomotion study and movement trial, they both have seen that if we are using teclistamab versus a real world care, what is available in that population, then it's almost 2.3, 2.5 times it is much better. The response rate is almost 63 versus a 27% with the real world care versus a teclistamab care. Next slide. And we can see in these also with the movement and locomotion studies that if you're using teclistamab versus a real world care, the duration, the proportion of patients achieving response, PFS, everything is significantly better. So when we see these kind of data, our eyes brighten up that yes, this drug is going to do something new, something magical. And it is doing in almost more than 50% of patients, it is doing magic. Next slide. Next slide. Dhruv, next slide. Next slide, please.
He started sharing the screen again. तो उसका screen चला गया है इसमें.
Okay. So we can see that teclistamab is doing a good job by bringing many of patients in overall response close to 60%. But every new drug has some fallacies, some problems also, which we are worried. But initially, when this drug was launched, it was apprehended that it is going to cause a lot of CRS and ICANS, which is not the case actually. In real world, this drug is not causing that much of CRS ICANS. So we had experience of teclistamab in our centers, both as a trial and as those who can afford once it was approved. So we have seen that the patients are not having significant toxicities. So Dhruv, are you ready with slide? Next slide.
So slides are visible.
Yes,
Yes,
visible.
yes.
You can skip. You can next slide. Na? So this we have already discussed that the movement and locomotion both study have shown that the PFS is better, OS is better, and duration of response is also better. Next slide. And here also we can see that with each in different classes with the high risk drug, with the pentapop refractory in both the cohort C and cohort C, which has already received a CAR T. So in those patients also we can see the overall response was close to 52%. Cohort A was the one where they were not exposed to CAR T and not exposed to any bite, and cohort C, which have already seen bite and CAR Ts, and in those population also we can see the response. It's close to 50% response in these population in heavily pre-treated. Next slide. So it ultimately it has proven its efficacy. It has proven its efficacy in heavily treated high risk patients, but barring many very minimum side effects of infusional toxicity, like we see as anaphylaxis or CRS, this drug is very much safe and is effective in those who can tolerate. So should be tried and used. Next slide. We, as a part of CRS, we see fever. Fever is very common, and as part of any drug which is playing with hemat malignancies, so the neutropenia, thrombocytopenia, they are common, and it is here also. The thing which is worrisome is infections. So because it kills plasma cells and it kills plasma cell to the extent of MRD negativity, so normal immunoglobulin production also gets sacrificed. That's why we see many patients with teclistamab having a very low IgG level, and the risk of infection increases. So a good vaccination and antibacterial and antiviral prophylaxis is very important, and need to manage hypogammaglobulinemia also. Next slide. So we see what is CRS is cytokine release syndrome. It's not specific to this drug. It's a problem which we see whenever we have a uncontrolled inflammatory response, like we have seen in COVID also, we see in HLH. So there are tumor necrosis factor and interferon which come into play when we see macrophage and T cell activation. And what happens in CRS, it's like fever, patient's blood pressure goes down, patient needs oxygen. So if it's only fever, it's grade 1 CRS, we don't need to do anything. When the BP starts to goes down, it is grade 2. Whether we need inotropes or not, that depends, grade 3 and more. So grade 1 CRS is easy to manage, only antibiotics is good enough. Next slide. So CRS is important, and CRS is related to many factors. First is very important is disease related factor. If you have high tumor burden, then it's as simple as a TLS. So we are seeing more and more tumor lysis, so we can see more and more CRS if the disease burden is very high, and especially if the therapy is immune modulating therapy, which interferes with our immune system and which comes into play along with a T cell activation, then the risk of CRS is more. Patient-related factors are there, but they are not that much important. Next slide. We see that with tocilizumab, almost 50% patients had grade 1 CRS, which are easily manageable with paracetamol, and grade 2 CRS was seen in another 21%. So close to 70% 1 and 2, which is smooth, no need of ICU, only prednisolone, some needed prednisolone, otherwise PCM is good enough. Next slide. So grading is as per CTCI, we know, and we are doing these grades. And when we are dealing with our transplant patients, then this CRS is very easy to manage. Next slide. So next slide. As we know, if the toxicity is very high, grade 3, 4, use tocilizumab, don't spare it. And otherwise, paracetamol and dexamethasone is okay. Next slide. Next slide. So it's the same thing. So pre-CRS, we need to monitor the ferritin, we need to monitor the CRP to see the pre-treatment inflammatory milieu of the patient. If ferritin and CRP are very high, like the score which we use in CAR-T, CAR-Tox or hematotox score, if these are high, then the chances of CRS is slightly more. If there's disease burden is high, then the chances is slightly more. So we won't be doing much with this, but it can predict and it can help us prepare better. If the patient is having huge disease, excessive disease, then the use of tocilizumab can increase the risk of ICANS. In those cases, it's better to use anakinra rather than tocilizumab, because tocilizumab will take care of only the CRS part, whereas anakinra will take care of both the part. Next slide. So neurotoxicity is important. You need to observe your patient for first 10 to 12 days, and it comes immediately after CRS, usually by the end of 6th, 7th day. What we are seeing that whether the patient is well oriented or not, he knows their name, which place, well orientation, he can speak, he can write. So what I do in my CAR-T patients, I've already explained them that these are the side effects which we see, but with the eye scoring and icons, I've given them a diary to each and every patient, and I ask them to write their डेली रूटीन वट एवर दे आर डूइंग, कि आप इसको बाद में जैसे पब्लिश करते हैं ना ऑथर, इस तरह यू ट्राई टू राइट वट एवर यू सी, एंड आई see whether their comprehension is okay and their handwriting is okay, it is not changing, that means the icons is at least not there. So we can catch the encephalopathy and PN. Next slide. So in ICANS, because of inflammatory milieu, there the increased leakage of vasculature. So small vessels, there increased vascular permeability, and these IL-6, they cross blood-brain barrier and they causes the problem. So there can be speech disturbance, there can be consciousness problem, there can be cognitive function and motor dysfunction also. So like HIDEC, I check the cerebellar functions, their pronation, supination, and writing, and they're discussing every day. When we talk to our patients, I know whether they are landing in ICANS or not. Next slide. So ICANS and ICE, these are immune effector cell-associated encephalopathy score. So we, as we know, time, place, person, and then we ask them to name objects, and you discuss questions, answer, you see their writing, what they're writing, you ask them to count it backwards, 100, 90, 80, 70, 60, 50, like if they can do this, then it's okay, no ICANS. So if the score is 0, it is grade 4, and if the score is 10, it is very good. So 10 out of 10 is okay, and we want that only. And the drug of choice for ICANS is anakinra, which has to be imported on name basis. So if the disease load is very high and your baseline ferritin is very high in whatever you are doing, then please try to arrange anakinra. Next slide. So IMWG also specifies certain things like grading, which we know. If the patient is not having any significant problem, then it's okay. Otherwise, use dexamethasone without the fear that this will compromise your efficacy of drugs or CAR-T. So use DEXA generously at that time, because saving patient is more important than later part of the cycle. Next slide. So we can see that ICANS is not very significant, and almost 96 to 97% didn't perceive any episode of ICANS. And of those who have done a neurotoxic event, the grade 1 was maximum, almost half of them was grade 1, and grade 4 is less than 1%. So 0.6% neurotoxic event is this, which has seizure, and mostly they had grade 1 and 2, which is self-resolving. So next slide. Serious infections in multiple myeloma is very important, right from their newly diagnosed multiple myeloma, because of their compromised immune system and immune paresis. So we need to take care of this infection with the appropriate vaccination, then levofloxacin at least for first 3 to 4 months when there is immune paresis, then antiviral, antibacterial, Ceptran, all these are important, especially in case of CAR T cell or a post-transplant, when the immunoglobulin G level is very low, then the risk of infection is more. So with these, you need to monitor IgG level. And if it's less than 500, some take a cutoff of 400, then we need to replenish the immunoglobulin level. Half gram per kg body weight, it's 3 to 4 weekly. If the patient is not having infection, then it's good. These are the important serious concern, which was with other bites also. And because of this, the drug manufacturer and researchers have tried to give a space of 2 week or 4 week once the patient have achieved more than.
Sir, sorry to interrupt you. Please conclude your talk in next 2 minutes.
Okay, it's next slide. So there are different factors which can increase infections. Next slide. So we need to screen those who are more likely to have a reaction. Then we need to give them prophylaxis, IVIG replacement to those patients if they are having neutropenia. Need to manage with growth factors also. So these are important where we can do and we can save our patients from infection. Next slide. Next slide. So levofloxacin is important, then acyclovir, valcyclovir is also important, and Ceftriaxone is important. And apart from these, do vaccinate your patient for influenza, pneumococcal, and possible for Shingrix also. Next slide. So IVIG replacement I've already discussed. If the level is less than 400 and risk of infection, then do give IVIG at least monthly. Next slide. So these are main three side effects. The drug is very good, but the side effect which we fear is CRS and neurotoxicity, which are easily manageable. Infection is a serious concern, which can take a toll, and it needs your patient to be repeatedly admitted, costly also. So this is one part where we can act better. Next slide. So over last 5 to 6 years, I have understood that we need to use our best therapies upfront. Use it earlier. Don't give the disease time to become resistant, and try to have a combination, because the biology is very complex, and continuous therapy, including teclistamab. They give you deeper and durable response. Infection is a major problem, so we need to treat our patients. We are not treating myeloma disease. We are treating a subject who is having myeloma. So we need to take everything into account. Thank you.
Thank you, Dr. Prakash, for your very excellent talk. And it's actually a new arena of the class of drug, which have very specific side effects, very specific effect also, and it has generated a hope in the patient where we have nothing to offer actually. So thank you very much, and
Technical team, kindly stop the recording.
be there. And I would for the speaking on the very nascent topic, that is a what is that, Letermovir for an uneventful transplant journey. So Dr. Prakash Singh Shekhawat, as I introduced him earlier also, he's a consultant medical oncologist and bone marrow transplant specialist and CAR T-cell specialist in our hospital, Bhagwan Mahavir Cancer Hospital in Jaipur. So he'll be speaking on this new drug, Letermovir.
So thank you, sir. I'm back again. And are my slides visible now?
Yeah.
So I'm talking about this drug. It's a drug which has recently been approved.
Yeah, but can you make it a full screen, sir?
Yes, sure. Okay.
Yeah, it's okay.
Yes.
So it's a new drug recently been approved in India. So why we are talking this? Because we know post-transplant, peri and post-transplant viral infections are very important, and especially when the T cell function is not there. So CMV is one of the very notorious common, because most of us, almost 96% Indian population is CMV exposed in their childhood, unlike Western world. So CMV is likely to get reactivated, and it has different effects, direct and indirect effect. Direct effect are like CMV viral syndrome, when we have fever, malaise, myalgia, leukopenia, thrombocytopenia, and it can cause anything. Like my boss used to say, CMV can cause anything except pregnancy. So you can have liver dysfunction, cardiac dysfunction, then your GI, then colitis, diarrhea, nephritis, pneumonia, everything. So this is a very bad infection, and especially because it can cause to loss of graft. So whole purpose of transplant fails if we can't control this. So what happened initially when you are immunosuppressed because of the conditioning and this treatment part and the GVHD profile excess, your CMV viral load increases, and ultimately it leads to a stage when there is infection and it becomes more pronounced, and it involves many systems, and it becomes a CMV disease. So if it is only steroid, it's on the extreme left, and when there are anti-T cell antibodies, it can lead to CMV disease. So the risk of CMV reactivation is slightly different in transplant patients, hematological transplant, compared to a liver or a kidney transplant. Hematological transplant patients, the risk is maximum when the donor is positive and recipient is negative. Second highest when the recipient is positive and the donor is negative. And it is slightly okay when both are exposed, and best is when both are not exposed. Need to use leukofilters, but it is good. And allogenic transplant increases the risk, and how much immunosuppression you are using, then the risk of graft rejection, and if you are having elder age and other viruses also, then the risk of CMV infection increases more. So refractory CMV, when we are unable to bring down the level in 2 weeks of appropriate antiviral therapy, it is refractory, and resistant when we have at least a genetic alteration which gives it as a resistant to at least one or more drug. So this resistance, genetic resistance, should be done when we are not seeing result. We used to send our samples to Medgenome for CMV resistance. So the earlier CMV gets reactivated, overall chances of stem cell success goes down, and it is more likely that your patient will fail. So positive CMV seropositive status is a strong prediction that it is going to reactivate, and almost half of our patients do see a CMV reactivation in their transplant course. So these half are complicated because we need to cut down the immunosuppression, then the GVHD flare up, we are again putting on immunosuppression. CMV comes when we are using drugs for CMV, myelosuppression comes. So this is problematic. So early CMV reactivation is associated with increased NRM. And we can see it across all the disease like AML, ALL, MDS. So increases the MRM and decreased overall survival. So letermovir is a drug which has recently been approved in India. It's a CMV specific. So it is not going to do for EBV, not going to do for our herpes also. It is a CMV DNA terminase complex and has been approved for hematological transplant in more than 6 months and more than 6 kg patients. And it has also been approved for renal transplant in high risk patients when the recipient is negative and donor is positive. So it's highly specific to CMV, at least more than 1,000 times more potent than ganciclovir. So we can call it a dasatinib of our uh, TKI compared to imatinib. It's 300 to 400 times. So same is with this, and it has been found to be active against some of the ganciclovir resistant strains also. But we need to keep this in mind when we are adding letermovir, we need to add something for herpes also. So many try to skip acyclovir when they are adding letermovir, as the reflex goes with Valgan and ganciclovir, but this is different. So we need to add cyclovir. So this was the study which has led to approval of this letermovir. What they did that they have used letermovir for first 100 days. So they have started letermovir usually by the end of first week, 7 to 8 days, and they have continued it till week 14, and they have seen that in the letermovir arm, the CMV reactivation is much less compared to the placebo arm. So it was almost well matched, 2:1 randomization, and HLA matching, haplo, stem cell source, they were all equally matched. Next. So we see that at week 14, after transplantation, significant CMV reactivation was less. It is 6.8% versus 41% in placebo. So we can see the curve on right side, huge difference. And it doesn't need any more explanation and justification that why we should use this. And at week 24, we can see still the CMV reactivation in letermovir arm was less compared to placebo. So this 6.8 to 18.9 is because when we are stopping letermovir at day 100, then some of the CMV again gets reactivated. So the thought came that shall we use it for more? Because when we are using letermovir in our transplant patients, it is decreasing our mortality in both high-risk groups and in low-risk groups. And the effect is more pronounced. In the middle curve, we can see the effect is more pronounced in the high-risk group. It is way better compared to placebo. In low-risk group, the effect is almost so close, but although statistically significant, but not that much. And it has proven its benefit in all except when it's a MMUD, mismatched and a unrelated donor. It's a double whammy. Donor is unrelated and donor is not match also. So unrelated haplo, where this drug has not shown any significance, otherwise it is good. And benefit of this over a routine valganciclovir, because kidney people doesn't need letermovir that much because they are using valganciclovir, they're using ganciclovir because they are not worried about myelosuppression, whereas our graft fails very easily when we are using valgan and gal in early part, especially in first 1 month. So with letermovir, there is no myelosuppression and there is no risk of nephrotoxicity. And when we are using it, there is significant difference in CMV reactivation, almost 6 versus 48%. But what happens if we are stopping this? That's why this another study, which was an extended duration study for letermovir, they have given letermovir 200 days to all patients. Then 2:1 randomization. Some patients, they have took off the letermovir for next 100 days, and in some patients they have continued the letermovir from day 100 to 200 days. So till day 100, all patients, next day 100, half, and one arm was placebo. So they have seen that those patients who are continuing letermovir for 200 days versus those who have stopped at 100, still we can see that the CMV reactivation chances are very less. The failure is, it's a p-value is 0.0005. You can see the difference. So as week increases from 14 to 28, it's best. From 28 to 38, it's slightly lesser. Than 38 to 48, it's further less. So some people are thinking of continuing it more than that, but 200 days is good enough. It's almost close to 7 to 8 months of transplant. And by the time your T cell immune reconstitution starts to happen, so we can take that. So if we are seeing at 28th week, means day 200, then in letermovir, the risk of reactivation is 1.6% versus 17% in placebo. Mind these 17% have already received letermovir till day 100. Otherwise, the risk is almost 60%. So if we can extend the duration of this drug from day 100 to 200, we can further benefit our patients because the risk of graft rejection and CMV reactivation both are improved. So we'll skip this and we can see, I've already discussed, most important, what happens if a patient gets CMV reactivation? He can have CMV viremia, CMV disease, CMV syndrome. So if it's a CMV disease affecting multiple organs, then they need to get admitted. And they have seen that the risk of CMV infection increases the cost because patient needs ICU admission, their graft fails, they need more and more blood product stabilization. Some patient needs boost, stem cell boost also. So if your patient is not reactivated, then your chances are better. Otherwise, without letermovir, in those placebo cases, we can see the all-cause rehospitalization rate is higher in all time period. So if you are not using because of reactivation, your risk of admission is more and your finances also consume more. So this reduces the risk of rehospitalization. It decreases the length of stay compared to placebo. It decreases your cost and it improves your HSCT outcome by stabilizing graft, by not interfering with your immune suppression. So dosing is, it's very simple, can be taken with and without food. It's a tablet which comes in 240 and 480. Both strengths are available. So anyone who is more than 6 kg is eligible if he is a allotransplant candidate. If we are using this with cyclosporin, then the dose is half 240 mg. Otherwise, if you are using with tacrolimus, then it is 480 mg full dose. So no dose cut off if we are using tacrolimus. If you are using cyclosporin, cut the dose to half. So these are weight-wise dosing, different weight, different age, and the dose, what we can do. Shelf life is almost 2 years, should be stored below 25 degrees Celsius. So I would like to say that this drug is very important. It's like a breather for transplanters, especially like us. And in our country, when the drug is needed to tackle down this virus. Otherwise, many of our transplant patients fails because we cannot control the CMV. Thank you.
Thank you, Dr. Prakash. We learned a very important topic and new things. I remember in my transplant posting, we had one lady from Punjab where we had done the May-generated transplant in the MDS, right? And she got the CMV reactivation. It was the hell of our life. We all the residents were on the toes for 35 days, and we had to use Foscarnet for that. It was a TID infusion, and we need to monitor everything: electrolyte counts, this reactions, infusion reactions, and life for hell actually. So if this drug would have been before, it was a smooth journey, and I guess this letermovir will change the perception of the people and the patients. It's a good drug. So thank you very much for giving the talk, and you had given two talks, so both are very excellent. Thank you very much.
Thank
And
you.
for this note, we will end this session. It was a fourth day, and we had learned many new things with our experience and esteemed faculties and the this panelist and all that. And as you have all seen, like Dr. Manish Singhal has done the good moderation of the topic, and everything was very prompting, and you can see the insightful. All the speakers were very wonderful, uh, starting from Dr. Sandeep Jasuja, Dr. Lalish Sharma, Dr. Abhishek Sharma, Dr. Tarachand Gupta, and Dr. Prakash Singh Shekhawat, Dr. Sachin Jain. And I would like to thank our academic partners, pharma partners, Dr. Reddy's, AstraZeneca, Cipla, Zydus, Merck, Roche, Prajnas Kabi, Natco, Johnson& and Johnson, Delag, Bayer, Intas, Glenmark, Isai, Pfizer, Amcure, Vitaris, Medgenome, Samarth, and Ferring. And thanks to the team Horizon who has made this possible, given us the platform to talk and discuss about the newer researches of the important cancers. And I would say, like, if we don't have this kind of the discussion and the webinars, we will be lagging behind a lot. So thanks for participating all the faculties, and thanks to the pharma colleagues, thanks to the tech team of the Horizon and the Horizon group. And we will meet again in the later part of the year with the new ESCO and ACE guidelines and everything which has come up in the forthcoming 6 months. So thank you very much and good night. Have a peaceful sleep and sweet dreams. Thank you.
Thank
Thank you.
you, sir. Thank you. Thank you, everyone, for joining. Thanks to our academic
Thank you so
partners.
much. Thank you for joining.
Thank you. Thank you, Dhruv. Thank you, Surangi. Thank you, Tripti. Good night, everyone.
Thank you, ma'am. Technical team, please close the